right, it is 5 o'clock, so I will call the meeting to order. Roll call.
Linda Hoke.
Present.
Lindsay Keisman.
Here.
John Reinert. Carolyn Schofield.
Here.
Amy Rath.
Here. Any public comment? All right. I need a motion to approve the minutes.
I'll make a motion to approve the minutes of the January 28th, 2025 meeting minutes.
All right.
Second.
All right. We vote on all in favor?
Aye.
Aye. Thank you. Agenda items for discussion. First is the fiscal year 25 outcomes summary report for Q1. I have hit you. Do I?
I'm on. All right, thank you. So we can go ahead and move to page 4 of the agenda package. And we'll start with the fee-for-service grant purchase of position outcomes, and this is under the levy funding. For the sake of time, I'll keep to the highlights, but please let me know if you have any questions. We'll start with the good news. Domain 2, abstinence reduction in use, was above network target. I wanted to point out a couple of notable details on this page. The first one is what we spoke about at our last meeting, and that is no providers selected to report on Domain 4, education and employment, or Domain 6, criminal justice involvement. This is due in large part to the tools that the providers have selected for measuring their program participants. Secondly, we are seeing some large differences between the network target percentages and the actual improvement reported. We were kind of expecting to have lower numbers, primarily due to the change in tools that the providers are using. Initially, last year, we found the majority of our providers were using agency-developed tools to measure progress for their participants. And over the last fiscal year with the application, we had requested that they select an industry standard tool if possible, and many of them have done that. So that could be part of it. Secondly, I wanted to make a couple of other mentions. Prior to year 2023, we only collected improvement percentages. And we are under the assumption that the network reported those who are maintaining and improving all under that metric, because otherwise they would have to say that the people are not getting better or doing worse. Factored into these target percentages for fiscal year 25 are 3 years worth of data. Only one of them include that factoring into the maintenance percentages. So again, we kind of had a feeling we'd be higher than what the network meets, but these are pretty low numbers. The other thing that we kind of investigated, and we actually talked to the network providers at quality management team meeting, is as we know, prior to 2025, we requested that our providers report on 2 domains. They had to select 2 and report on both of those. We had one of the providers say, well, I know that we're not reporting on Domain 3 anymore, and we had pretty good numbers. So we took a look back to see just what the difference was between how many were reporting in each of the domains. So domains 1, increased knowledge and resiliency. Domain 3, increased level of functioning. Domain 5, housing stability. And Domain 7, social connectedness. Those are the ones we're seeing that are below network target. We looked at what was reported in fiscal year 24. 105 programs were reporting across those entire domains added together versus 48 this year. So it's a large difference in the number of programs that are reporting under domains. So to that note, I took a look at what we were projecting for target percentages for fiscal year 26, because those were on our applications, and we were able to use the maintenance data, and they are definitely lower than what we see in fiscal year 25, but they're still not anywhere near what's being reported right now. We're only in the first quarter, so we could see that maybe there's some changes, some good changes coming about as our providers get used to using different tools. However, I'd like to propose, and I know Amy will likely say more on this, but potentially at our November meeting, taking a look at what we're seeing after the 3 quarters of data and taking a look at what we've projected for targets for fiscal year '26, and do we have to maybe redo some of those?
Great, thank you so much. Any conversation on that? All right.
Thanks.
No?
Oh, it's
I-
green, but this is not green. Can you hear me?
You're not green. Let me.
Me first then, I guess, this time. Karen, I have a question. You said that, as some of the other providers fell off because they selected a different domain, but they had pretty good numbers, how apples to apples are programs that, like, let's say we pick housing stability, or maybe you could give me an example, but I'm just sort of curious. Clearly the ones that fell off decided that there was a better primary domain, and that was the secondary that they were talking to. But I'd like to know, are there programs that are left over in some of these categories that should be looking to some of the other providers for best practices?
I would say it's probably an apples to oranges comparison. I think
Okay.
we're looking at more prevention providers are moving into different domains, and a lot of these are treatment providers, and quite a few of those programs are dealing with some of the higher need clientele. So clients who are going to need additional services, some who have additional diagnoses or more challenging diagnoses to work with. So I think we're seeing kind of quite a few different reasons for what we're seeing.
And one more question. Year over year, for programs that have been around and are still in the same domain, are they tracking steady?
A lot of them have changed their tools.
Okay, so we can't know that. Okay, thank you.
Okay, thanks. Yep, I'm gonna. Do you know, how are they selecting the domain? Are they choosing it based on where they want to see improvement?
They're selecting it based on the program type that they have. So they are selecting that with the application. And then they're selecting the tool that they would use to kind of measure that. So it should really be program-based of what they're looking to accomplish in that program.
So I guess I'm wondering if, because how I look at it, if I were to select, it would be kind of an area that you're setting as a goal too. And I don't know if that's kind of skewing it. Like if, when you had everybody reporting, they were reporting in areas that they've already mastered and didn't need to necessarily address. And now are they selecting ones that they maybe need to focus more on and are wanting to address? And if that's a factor of what's kind of making that differential greater.
It could be. I know one of the providers had selected housing stability. However, in looking what tool they were using, it didn't really make sense that really wasn't a tool for housing stability. So they were moving into increased level of functioning. That particular provider, actually, they're kind of looking at that a little more closely, and they're already saying for next year they are probably going to look at a different tool.
Okay. Yeah, I think we kind of need maybe the new system for a little bit in order to really figure out how it makes sense or where we need, how we evaluate it. So thanks.
I have a question too. How are the expectations, how are the targets set? Is this based on national targets, or is it based on our expectations or their expectations of what they would meet? It could be we've chosen targets that are maybe a little unrealistic in some areas, and I don't know how the ones this year were chosen.
Sure. So it used to be on national standards because we had no metrics that we could track. We didn't have percentages, so when we started tracking percentages, that's when we started using other benchmarks to set those targets. After several years of collecting the data, we then started using our network aggregate, and we select the target, and we use that aggregate to set that target. Usually we're going just a little bit above what the network has achieved, so we're not just maintaining status quo. We do have some providers, though, that have said, okay, I'm going to report under this reporting domain. However, based on the clientele we have, based on the national averages, that's high for us. And again, we do have various programs, some that are more prevention-based, some that are working with clients that are, it's a little easier for them to get back into the swing of things as opposed to some others that are just going to have ongoing challenges. So we set a target on the application, and then the provider can put what their target is. And so we've advised providers, if you feel that that network target is not reachable, you want to put what you think is reachable.
I have another comment. It's going to sound like teaching the test, but that's not what I'm saying. I remember when I was at the hospital, they had us script certain things, saying that there are things that we do all the time, assuming that people understand the reason. So when you come in and close the curtain, say, I'm doing this for your private, like they had to script those things, because then when they gave the satisfaction survey, people are like, oh yeah, they mentioned privacy all the time. So I don't, it's not necessarily teaching the test, but if the questions are different, the answers aren't always in keeping for what we're looking for.
True, true.
Some of the thoughts that I had, so thank you. I think that really good discussion. I did meet with Karen ahead of time, and the one that jumps out to me in particular, because in my day job, I do corporate learning measurement, is increased level of knowledge. That is an extremely, we actually stopped measuring it, and I work again in learning, where you are supposed to be increasing your knowledge, and found that that is such an incredibly difficult target or topic to measure at all, because many people come in with some sense of baseline, and it's entirely subjective. Did I actually learn something new, or did I really not learn something new, but I still got the information that I needed to know? So what we've switched to is this met my needs. Like this was the information that I needed at the time I needed it, and it met my needs. I know that's very wordy, but I realized that even what I'm talking about is not a direct apples to apples comparison other than the wording of the measurement. But if you do have somebody who might feel like, I knew what I was supposed to be doing, I just wasn't doing it, or this wasn't new information to me, or I was aware these resources were there, I weren't taking, any of those, you could see it's very, very normal, at least from my perception, for increased knowledge under Domain 1 to be quite low scores, even if the program and the services they're getting are meeting their needs. So that one in particular was one that I wanted to revisit, as opposed to some others, like housing stability feels a little bit more objective. Again, that score is also lower, but you're not asking somebody to rate how much they knew about something. So those were some of the thoughts that I had. I see that Lindsay, so.
Yeah, I have a kind of a follow-up question, because I know when we designed this, we wanted to have, drop down of topics or instruments used, right? And one of the things that, and this is from my specific knowledge area, right? Like, it still kind of doesn't make sense to me, when I look at some of this, Karen, like I'm looking at domains 1, 2, and 3, for instance, and they all mention a PHQ-9. And I have a hard time understanding why a PHQ-9 would be used for, like I absolutely understand why it exists in Domain 3, but it really feels out of place in Domain 1, and I don't think it would be like the tool to use in Domain 2 either. So, has there been discussion about, from us, looking at just the appropriateness of the tools that I have no doubt that maybe they just happen to be doing PHQ-9s, and are they just reporting that because they do them anyways? Because I don't really want PHQ-9 data on increased knowledge and resiliency, because I don't see how they're related. I don't know. I don't know what you've seen. I know it's our first year rolling this out.
Yeah, those are great comments. Agree, having been a clinician, I'm kind of in that same vein. I know for domain 2, for absence reduction and use, we do have one provider that is using not one of our industry standard tools. And from the research, it shows that one of the things that their tool doesn't quite cover is depression. And so they're actually using that in combination. So that's probably not their absence reduction use measure, but that's one of the tools that they're using to measure the clients that are in their services. For domain 1, I do know of at least one provider that uses like a PHQ-2. It's for a service that provides resources to get people connected, but they also use that in their clinic, and so they're also using that, but agree.
I think it'd be something to look at moving forward, that, as we're having conversations, it's like that we kind of wanted to standardize the tools, but we also wanted to do that because we wanted to make sure people, like, we could compare like things. So if they're using, let's say, my example, PHQ-9 data to support something that's in a category we don't think it belongs in, as we're rolling out this new process over the next year or two, I feel like that would be guidance that I would want staff to give if something doesn't quite hit the mark, and as other people in that domain are using tools. I mean, I think the spirit of what we were trying to do was like get like providers to use like tools so that we could actually measure effectiveness or compare apples to apples instead of always being stuck with this apples to oranges situation. So, year one rollout stuff, and I think I would hope to see some of that stuff sort of change into, or advice given in the next QMT meetings or something about, the summer applications and what they're picking to make sure that it actually makes sense, or that you as a clinician or our, staff expert would be able to look at the tool and say, I don't think this tool really belongs in this domain. If there are some obvious ones. And maybe we prune it out over a couple of years, but that's just some opinions I have. And I'm not familiar with every single tool everybody uses, but I know you'd have a better grasp on which things are actually a little bit more apples to apples.
Great, thank you. Thank you so much for that. Obviously, we're in a place where we're sort of looking at metrics and saying we need to just wait a little bit since it is such a big change, but it is still very interesting to see the information when it's coming through. And I know that some of these aren't the numbers that we're looking at, but it sounds like there's still a lot of reasons that we need to figure out as to why they're falling the way they are. And it sounds like we're also open to potentially revisiting what the targets are if it seems like they were not appropriately set. All right, so 4B, the audits conducted. We'll move on.
If you'd like, we can still continue with the outcomes. There's a couple more
sorry.
pages. No,
Sorry.
So on the next page, we just have information on domain 8. Well, actually, the previous page had domain 8 access and capacity. That just tells you how many people and new people were served. The next page shows the consumer experience surveys. So we are actually previous page, sorry. That shows the consumer experience surveys. We're doing well in that area as a network. It shows waitlist information and ineligible referrals. And just that added clarification, the majority of our providers do not have a waitlist for Q1, but we do have some providers that have some longer waitlists. Again, a lot of that has to do with if they have a residential component to their treatment. There's only so much space, and they have to wait for people to move on to their next phase of treatment, and so that's part of it. Additionally, we have another provider that provides ongoing service for individuals on a regular basis. It's something that until another payer source is able to pick up, they're providing that service. Any questions on that page? All right, we can move on to the next part.
I just have a couple questions, sorry. So do you find that on those wait list ones and the length of the time is somewhat dominated by certain providers?
It is, yeah.
Yeah.
There's just a couple of them.
And I can kind of off the top of my head guess which ones, but yeah, that's what I was wondering, if it's,
It is, yeah.
okay. And then with the ineligible, and excuse me because I'm new, what would classify an ineligible, and then what's the meaning, I guess, of the ineligible ones?
Sure, great question. So ineligible means someone's referred for services, and for some reason they don't meet the criteria for that program. We've asked the providers that if somebody just calls you and says they heard from somebody that you do this, we don't want those counted, because that's somebody maybe heard something from somewhere. If it's a provider, though, that's referred somebody for that program, we want to track that. Couple of things we want to track it for. We want to make sure that there's not exclusionary criteria going on. So if we see a lot of ineligible referrals, we want to make sure that we have eyes on that. Additionally, if we're seeing a lot of ineligible referrals and it's not an exclusionary issue, we want to make sure that we invite that provider to intake coordinators to maybe reshare about what it is that they do. So if it's anyone in our network that may be providing ineligible referrals, they at least can remind individuals of what it is that they do.
So do you find with those ineligible referrals that it's more just on the lack of knowledge of the provider, or do you find that there are gaps in services?
That's a great question. I would say it's probably more lack of knowledge, but there could be potential for gaps too.
So me personally, that's maybe the one area that would find that information useful. I just think if people are referring and they don't know, I don't know how we can really control that more than just educating them, but I was just curious for that reason. Thanks.
Yeah.
I had talked to Karen, I had talked to you today about the waits, and I understand that some things like, housing availability for IDD is a problem, and that it's a problem nationally as well as in the state. But I guess I would like to know where we compare in McHenry County with that, and if we should look at something maybe innovative, like in trying to recruit volunteers from churches or retired nurses or, something to try to at least provide some interim care for somebody who might be waiting, like we heard the other day, 13 years to get placed. It just seems insane to me. It seems insane, and we need to try to bridge that. And we can't put a stick of dynamite under the state to get them to hurry up, or the federal government, but is there anything that we can do? And that's not for now, but I think I'd like to just throw that out there as something we should discuss, because those kind of wait times don't seem okay to me.
I'm going to maybe echo and broaden what Linda just talked about. And Karen, correct me, but so like when I see these numbers, and it's always really interesting, and recently Carolyn and I were actually recently somewhere that was talking about wait lists, and I realized that there's a discrepancy sometimes in what we see as a wait list and what it actually means out there in the world. So when we look at wait lists, for me as a mental health board and what we're doing or what the staff are doing, I feel like there's waitlist issues that if there's a pattern or a theme, you gave an example with the IDD and the housing, that requires potentially specific creative solutions and knowledge that our board should have to consider for funding, those solutions. And that's different than the waitlist for psychiatric medications. That's different than the wait list for, outpatient therapy. That's different than the wait list for a detox bed. And so for me, I guess, statistically speaking, this number feels hard to do anything with because the data isn't useful, because we know we're having some outliers. So at least for me in this committee, I would love to see this potentially broken out either into categories, or even as we think about what we come back with as a committee for suggestions into, the funding cycle, it's like, is there, a new trend, right? It's hard for me to see a new trend when we're looking at kind of like I'll call it a high N if we're gonna, do stats. It's like, I don't even know what we're doing with it. But I'm gonna guess that in, our network council, they know, right? They know, what it is. But I don't always feel like that translates up to the board very well for decision-making. And so I guess I just wanted to engage in discussion as a committee. And I think you and I are the only people that are on this committee from last time, right? There was such a spirit last year of like, how do we make data be accurate so that it's meaningful in decision-making? And I think we started that, and we're still in that kind of developing phase of seeing where the data is going and getting it clear and accurate. But in the meantime, waitlist feels like low-hanging fruit for me for us to categorize that slightly better, even hear what staff recommendations are, strategies or innovations, unique partnerships out in the community that could solve some of these. So I don't even know what I'm asking for here. Maybe what I'm asking for is I wish this waitlist data was a little more specific.
And more hopeful.
Well, I don't know about hopeful. I mean, I'm a realist. It's like, I just want the data to be useful, and then we do the best that we can do, so like, I feel like my job is to take the money that we have and make the best use of it as possible. And this wait list category feels like it would be an influencer in my decision-making. And I wish I just had like a little better information about it. I don't think I asked a question, but Karen, any thoughts, feedback? Is there something I'm missing, or is there a report I could look at that would already do that?
Yeah, I did send out with the email on Friday, there was the detailed list of the wait list, and I don't know if that's helpful enough or if there's other ideas that we're happy to see how we can make the data work better for decision-making, for sure.
Well, what do you guys do as a staff? Maybe let me ask that, or and I don't know if this is discussed at QMT or Network Council, like, is there a process for looking at wait lists? And I know the agencies do a good job of trying to work together, so I don't want to talk about it from that aspect, but as staff, are there trends or things that you guys are noticing that then influence the recommendations that you make when you make your draft recommendations for allocation season?
If we're seeing a request that is, if we see in the application that a request says, yeah, we have this long waiting list and we need additional funding, we're looking at those numbers to see, does that match with what we've seen reported? As far as like finding new providers to contract with, that's kind of fallen into the executive director's realm. If we use it mostly for kind of using what's asked in the application. Does it make sense with what the data is that we're receiving? So if they're saying we are requesting additional funds to help knock down our wait list, then of course we would say, yes, we're seeing this in the data that's being reported to us.
Mm-hmm. Yeah, I'd love to, have the most recent data on this available for, and I don't want to speak for everybody, but the most recent data for this to be available and kind of in our face when we're making those decisions. And I know we're shy in executive director right now, but so much talk on the board has been about identifying gaps. And to me, this is data we already have that supports where the gaps are. And I know we can only fund whoever applies to us, but at the same time, that'd be the conversation that I think would make sure is not missed during allocation time. That like, here's a big gap and it's really, really needed. And here's also gaps that are really needed and there's no answers for, because that happens too. I'd love to focus in on the gaps that could have answers. So yeah, anyways, I'm just soapboxing at this point.
I'd like to add something to that. You mentioned the network providers, and it may be that the people in the industry are aware of what the problems are for some of these wait lists, and we could have a discussion with them, and it may involve local mental health agencies approaching the state about funding more aggressively or sooner, if that's what the holdup is. But I don't even know where the holdup is. So to me, I would want to know where the holdup is. You know, if it's housing for IDD, then that's something that should be able to be fixed. We're housing other people, and it's caregiving, and it's other things. But I don't even know what the main problem is, aside from waiting for beds, which is sort of nebulous. Like, why are we stuck in that situation?
Oh, sorry, thanks. And so I was looking at that chart, and I guess I didn't realize that was all of, I thought maybe it was the top one, but that's all of the ones that you used, right? And so on the ones in particular, how would a purchase of position have a wait list to it?
So that one, and I was looking at that as well, and it's probably because it's that same program, so they have purchase of position components to it as well as the fee-for-service component, and I think they're lumping it into the same piece.
And also with that same one, are they using the same individuals and counting them twice? Because they just seem to be the exact same numbers.
Yeah, they are. So the fee-for-service is the clinical component, whereas a purchase of position are like the bus driver, a nurse, and so it's those that are serving those in the fee-for-service program.
So, I mean, I guess that's like helpful information to understand that too, because is it just the way that they're moving them kind of through their system and there's, you know, just expanding the funds? I guess understanding more of that, maybe for when we come to allocations, that would be a good thing to focus on those areas and really understanding, because I do think as far as averages go, I mean, obviously that one provider skews a lot of that wait time and really understanding how we can change that. But then, I mean, I think the other thing is if you look at it, it's residential, is access to kind of.
Well, I think for that one, it's actually day programming. And so it's really that program is solely funded by the Mental Health Board. And so it's knowing
All
what they're.
three of them?
I
And you mean the,
Yeah, so the two that are of the same name,
yeah?
they go hand in hand. The other one is outside of that.
Okay, yeah, that's what I was looking, but then I was looking at the other providers too, and there's a lot of like residential component to
Yeah,
those as well.
for a recovery home,
Yeah,
yeah.
yeah.
That is it's a matter of space that's available.
Right. It just seemed like it was kind of the theme, like half of them have a residential component, it seems almost like. Yeah, and that's kind of it's a big fix. So, okay. It is, thanks for the information, it is very
Absolutely.
helpful.
Are we, like, just for math's sake, to me, it doesn't make sense to count 180 and 180 twice into the average.
I agree.
Like, from a stats perspective, you know.
Yeah, a conversation was being planned.
Yeah, okay.
No, I would just like to echo what everyone said. Those were really, really good comments. And I think that it would also be helpful to see some kind of, not to get to solutions or to say we need this now, but I think going into allocations, it would help me to see some kind of distribution by type of provider with something other than an all-up average, like seeing I think mode, like the kind of the most frequent number or the midpoint as opposed to the average, because in this case, the average is so polluted by bad data, not just double counting, but it's not the same. So I don't know that we would need to continue showing an all-up average of the wait list at all unless we were only looking within the same type of program. Because I don't want to dismiss the outliers, which I think is something where you don't know how bad it is when you're looking at an average. But we also don't want to, as you said, residential, we can't build a house tomorrow. So we need to take all of that into consideration. So it sounds like we'll move forward with thinking about different ways to report the wait list data. And I might volunteer to take a crack at some of it just to, although Greg was better than I was and he's not here. But I like graphs too. Okay, all right.
All right, we can move on to the opiate settlement funding. Oh, I'm sorry. Nope, we can move on to that. Thank you very much, Joe. So this is the additional reports. So some good things. We see increases in a way out and connect to recovery participants. That's facilitated through new directions. We also see a nice increase in mental health board trainings that are put on by our training coordinator and assistant. We also are seeing more mental health first aid trainings through NAMI. We're seeing decreases in naloxone distribution through Live for Lolly. We're also seeing decreases in QPR trainings through NAMI, but they are offering 2 additional types of trainings, ending the silence and mental health in the workplace. So it looks like their programming is being diversified a little bit across those different various programs. 2 good decreases to see in this report. Zeros would be preferred, but we are seeing a decrease in overdose and suicide deaths in the county in this past quarter. Any questions on that report? Now we can move on to opiate settlement funding. So really good data here. We only have 4 programs that are reporting on this. Domain 1, well above the target. Domain 2 is also above target. So nice job to those agencies that are providing this. Any questions? All right, we can move on to the...
This is, sorry, just a quick comment. This is one, I'm really going to watch that increased knowledge, because to hit 100%, my only expectation would be that maintaining then becomes the high one, and that drops going forward, because I already talked about it a bit, but it is such a fuzzy statistic. Okay.
Sure. All right, moving on to access grant summaries. These are our psychiatry programs. And so what we're seeing is we are below target for prescriber capacity, but just to bring everyone up to speed, we did lose, these are again 3-year averages. We did lose a psychiatry provider that provided a lot of services a couple of years ago, so we're still seeing some of the data that they helped with that's being factored into this. Additionally, a few of the providers for psychiatry access funding had been reduced in fiscal year 25, and that was based on looking at their utilization in fiscal year 24. So we are seeing a decrease in capacity. Just as a reminder to our board members, we do have a new question on the fiscal year 26 application for the access providers. We are asking them to put in their prescriber capacity projection. So we're finally going to have a metric that our board can then take a look at. You're asking for this much money, how much are you projecting to be able to serve, or how many hours can you commit to with that funding? So this way you'll get a little bit better apples to apples comparison when you're looking at those applications. We're also a bit below the average target for utilized hours. Again, with reduced capacity, we're going to see reduced utilization. But we are seeing the wait time is below the maximum target. New clients served is also slightly lower than what we saw this time last year. Good news is we're seeing average cost per client and hour of service is much better than what we saw last year. Productivity is also better. We want to see what your capacity is versus your utilization, so we're seeing that gap is being closed this year. Average level of functioning is also above the network target, which is good to see. We're seeing the client-reported hospitalizations much higher than what we saw last year. I think this might have been one of our providers that may have been reporting a higher number. We need to go back to that provider and clarify if that's accurate or not. We do have the client-reported crisis services as well below target, which is also good to see. And then the consumer experience services, or consumer experience surveys, is at 93, which is right on target with our network target. And then it's also good to see that the ineligible referrals are not very high. Any questions on those?
All right, thank you. So that was the outcome summary. I think we're ready to move on to the audits conducted.
All right, so this will be shorter than you will see in future meetings. So just a reminder, our compliance audits, we review quite a few things at audits. We're looking for releases of information to make sure that we have the privilege to review these files. We're also looking for appropriate clinical documentation. We're reviewing that the person is a McHenry County resident, that their service notes documented for the services that were provided. We also look at HR records, including credential verification, payroll and background check verification, and any other funding agreement, data reporting, special conditions, requirements. We also keep an eye out for state and federal regulations, accreditation standards, and best practices. So it's pretty in-depth, and our providers will probably share that, but we look at quite a few. So typically in this meeting, we've kind of stuck to the recommendations for the audit reports or audit summaries. If anyone has a different preference, just let me know. All right. We'll go ahead and start with Family Health Partnership. For them, we're requesting that they look into revising their general release of information form for the Patient Navigator program. We want to make sure that the ROIs are valid from the date that services start for the mental health board from when they report them to us. We're also requiring that they improve how soon the licensed professional of the healing arts signs off on the treatment plan, because that's what makes the treatment plan valid. And the therapist will develop the treatment plan, but the licensed clinician has to sign off on them, and that's the authorization that it's a valid treatment plan. So we're asking them to close that gap. And then this is one that's doing the PHQ screenings. We are doing checking of outcomes when we go for audit. We want to make sure that outcomes are being measured. So we are looking for those in the consumer records. And we did see at least one, maybe two, that didn't have those screenings in there. And so they're going to revise their process to make sure that they're accommodating those on a regular basis. And we'll move on to Clearbrook. Oh, sorry.
Karen, where did the 45 days come from as a recommendation?
So that is from state requirements.
Okay.
Ideally, it would be sooner than that, but yeah, that's the threshold that needs to be signed by then.
So if it's within 45 days, they won't have a recoupment?
Correct.
Okay, all right. Yeah, definitely not best practices, but I'm worried about the money, so, okay, thanks.
Yeah. All right, Clearbrook. For Clearbrook, we just had some release of information issues with some of the charts. They recently added a team member that will help with making sure overall program process improvement. And then for New Directions, there was a couple of records that had lapses in releases of information. There was also some staff changes, so we requested that the executive director meet with our fiscal operations manager to go over the mid-year reconciliation process. For Warp Core, they had a couple of process improvement requirements in their street outreach program. We've requested that they include adjustments to their outcomes collection and consumer experience survey. We want to separate those out so that the consumer experience survey is truly anonymous, and then the outcomes is not anonymous. We're also asking that they include the consumer city on their program's release of information. And they also had several records with releases of information dated after services began. Moving on to Crystal Lake Teen Center.
Sorry.
Oh,
I-
yeah, sorry.
This came up with Warp Core, but it's a more general question, so if you want me to hold it till the end, I'll ask it. But let me think of how to say this. When we make the recommendation like that, like we want you to close your business processes up a little bit more, or whatever that might be, could you just talk a little bit, and again, maybe this is more appropriate at the end, like what teeth do we have behind that other than funding? Because I want to just understand we're doing more than simply making a recommendation to you, but we also still believe in your program. We believe in the good that it does for the community. So if you could just talk for a little bit.
Sure.
Thank you.
So yeah, anytime we make a recommendation, it's either based off of state requirements or our funding agreement requirements. So we make those recommendations, and we do look for them when we see them again. We want to make sure that those are being implemented, that the improvement is there. If it's not, that does get reported on the next audit report. So we do see some of our newer agencies, we see them more than once a fiscal year, just to make sure that they're keeping up with compliance requirements and make sure that we're available to answer any questions they might have. But yeah, then it gets brought up at this committee that, we required this, we requested this in the previous audit report. We didn't see the changes being implemented the next time over.
Thank you. That was helpful. And I realize there's been a lot of change that we've put on these providers over this year. We've asked them all to change their instruments. We're changing the way they're being measured. There's a lot of flux going on. So I wasn't asking that to recommend that we get more punitive, but I wanted to just understand it a little bit more. So thank you. I really appreciate it.
Sure. And then for Crystal Lake Teen Center, they were awarded funding for 2 programs this year, and we noted that there were some data reporting challenges. For example, a client that was reported under one program to us actually, when reviewing the service notes, they actually were somebody in a different program. So we've asked that they really work on that data reporting, making sure they're reporting under the correct program. We've also required that the executive director reach out to our fiscal operations manager to discuss the financial audit submission requirements, as well as clarification on mid-year reconciliation process, because they're funded this year under a purchase of position and a grant, and they just wanted some clarification on the right reporting methods for that. And then for Pioneer Center, their staff had to be very hands-on for the audit process due to their newer electronic health record system. Ultimately, what was shown to the auditors wasn't showing in a way that made sense, so their team member was able to show us on their computer the information, a couple of the information pieces that we needed. So we all worked together and were able to get through it. They had some release of information issues in one of their programs. The behavioral health residential program also demonstrated that there was a lapse in the integrated assessment and treatment plan. If that were a fee-for-service program, we would have recouped for that, but it is a grant program, so there is no recoupment tied to that. We also noted that one of the mental health professional level staff didn't participate in clinical supervision during one of the audited months. That's a special condition, and it's a clinical requirement in Illinois that anybody who reports as a mental health professional does need to have monthly clinical supervision. We did recoup $181.48. This was due to a missing service note in the PADS program and also a missing individual service plan in the IDD warrant of need program. We go by the stance if there's no treatment plan, you can't really provide treatment. So any services that were provided under something that didn't have a treatment plan is recouped. And then we also reminded them that mental health professional staff are required to have monthly supervision.
Can you explain that?
Yeah, so anyone who's reporting as a mental health professional, they're using a designation to show that they have some professionalism in this field. But they're not licensed. They're usually not even a provisional license, that first licensure, like an LPC or an LSW. And so anyone who's not fully licensed, LCPC, LCSW, they need to have supervision. Okay. And then Child Advocacy Center, they recently incorporated a therapist into mental health board funding. So there's a portion of that grant that's being funded for the therapist that's on their team. This therapist provides short-term focused therapy. There was not a compliant release of information for the mental health board for those therapy services. So we are requiring that they revamp their release of information to make sure that the mental health board can review files under that as well. And that's all I have this time.
Karen, what kind of regular ROI training do we need to do for them? Because this, I mean, I've been on this committee since I've been here, and I feel like, God, if I were to throw an estimate out there, like 75% of the time, that's a problem. And, you know, I want to harp on it for a little bit because it is the gateway into us accessing the information that we're requiring. So if it's not there, then we're not auditing it to a level maybe that we want to. And I realize it's a pain, and I absolutely hate getting ROIs in short-term care and, you know, making it a paperwork step before a human interaction. But I'm just kind of curious, like, what have you already tried? Because I'm sure you have done many things with this, but I just don't get if this is like a required training we should have or develop or something, because it just seems to be a cornerstone issue with every single audit meeting that we're ever going through.
I think part of the challenge is we can provide the training and we could provide the guidance, but are the people who need to have that training attending? That becomes part of the challenge too. So we go over things at quality management team, but then it's a matter of, is the oversight there for the person who's doing the documentation? So we can do what we can. We're happy to investigate different things, but I would hope we'd see improvement, but I'm not sure at this point yet.
Is this worth a network council topic? Like, I know that that is a slightly different type of event than this, but if we came in, I mean, I'd be happy to volunteer and put on a frowny face and say, explain to us why this is a problem with everyone. Maybe some live brainstorming could dampen it for the next round of audits. Maybe. Okay, I'm happy to coordinate that. I have no problem doing that.
Yeah, we can absolutely bring it up as a topic for sure. Thank you.
Oop, sorry.
Usually when it's some simple thing like that that's important that gets missed, it's something that requires a process change, like, I don't know, a sticker or an electronic stop, or, you know, depending on what their records are. So to me, the education needs to be, the education can be done, but they're going to have to take a step to make that part of their process, because we can't put that process into however they're doing their records.
Karen, when we have them put together the work plans, is that a part of the work plan? Like, what is your systematic procedure workflow to ensure ROIs for the mental health board?
I believe the ROI language is probably in the contract. If it's a brand-new provider, we absolutely go over release of information. We're letting them know, we need you to develop this. We need this to be part of that process. For providers that we've funded for some time, it should be a given. But yeah, the work plan is a lot about the program, what's happening in the program, what our expectations are, the data reporting aspects, especially if there's changes to the service codes or if it's a new program. But yeah, we do heavily with new providers.
I'm just curious if in the work plan, if we ask people to submit like an SOP on the, you know, ROI process for mental health board funded programs, if it would then at least enforce that they have an SOP on file that then we can reference back if you're doing an audit saying, you submitted this SOP, what is the issue within your organization as far as training and consistency with it? Because I just, it's, you know, I like to Amy's point, like, what teeth do we have? I mean, I don't know that we want to have teeth, but I think about it similarly, like, whatever, we all just had to do OMA and FOIA trainings, and I was not excited about doing that, you know, every year. But the reality is when you enforce yourself to train, to retrain, you hear it again, it's top of mind again, and I'm wondering if those are the kinds of, things that we need in place to, ensure that these things are happening. I look at that, and I've been, employed at places with grant funding that if that wasn't on file, like my bosses were like, we're going to lose money, like they're going to recoup something back. They're going to, and I'd hate to have us do something like that, but at the same time, when there are real consequences to it, it works. And if we're not going to have those kinds of consequences, perhaps we need to, add in, that they have to do, evidence of formal training of the ROI process according to the SOP that they develop once a year. I don't know. I'm just talking out loud, but I just can't, I can't believe how often this comes up, to be honest. And all we say is, hey, do better. And, year after year, I'm still seeing the same stuff. So I don't know. It's not working. We should change it.
All right. So that concludes the audits conducted. Moving on to old business. Not to take a vote or anything, but I asked that we add CARF accreditation on here because it has come up at the bigger meeting, but I don't remember discussing it in this meeting, and this is where it feels like it warrants a discussion since this is an accreditation in general, and we're the Ethics and Compliance Committee. There's a lot of benefits and drawbacks to carrying it, but I believe that originally it was something that the board pursued for something other than fun or just because, there was some reason that it was actually done. So I want to just make sure that I am understanding the topic as thoroughly as I can. So I had met with Karen ahead of time and posed a couple questions, which Karen herself is not the person to answer them, but I wanted to put them to this group. And those were, when we're thinking about our current CARF accreditation and whether it's something we would want to pursue again, I'll start with, I think, the more simple question first. Is there some benefit from a grant or funding perspective to our having it? Is there some way that us carrying some kind of accreditation enables us to get more money somehow from somewhere? And I think the answer is probably not, but I would want to not just assume that that's the answer, but actually ask the question and make sure that's the answer. And then the second one, so that was my one question, was is there some financial benefit to us having that accreditation? And then my second question was, is there some benefit to the providers if we have this accreditation? And in my conversation with Karen, she brought up that having that very neutral third party getting feedback from the providers could be a benefit to them. Yes, they can come to us if they have a problem, or they can, but there is something to be said about this isn't a member of the board, it's not a member of the board staff, it is truly an outsider looking for your feedback on the board. I don't know that that's $10,000 worth of benefit and all of the hours that go into the CARF accreditation, but it feels like if that went away, there could potentially be that gap. And I would want our providers to feel like they have a neutral method of being able to give feedback and suggestions on the board that isn't like a suggestion box in the corner where we promise it's anonymous, whatever that is. So I wanted to put that out there. I don't know if anyone else has any thoughts or comments on it. Karen, did I represent that conversation correctly? Do you have anything else that you would like to add on that particular topic?
I don't.
All right, so we'll just put that out there.
I'm happy to comment. I know we've talked about this in a couple of other meetings. You know, you have great questions, right? Like, does it help us get a grant, right? Is there any financial benefits, you know, to it? And I mean, I think the spirit of the types of grants that we would go after, you know, because we're not ideally not supposed to be direct service providers, or if we do take on that task, we're supposed to, I believe it's within 2 years, offload it to another funded agency. So, I mean, in theory, right, like maybe that would matter. Maybe that would make us a slightly better applicant to, you know, a grant reviewer, depending on what we would go after. But I don't know that we're going after things like that. You know, I think we're trying to be a conduit to our funded agencies through the grant writer that we've contracted with, or going after things that are, you know, related to our building or, you know, infrastructure or whatever might exist out there in the world that I don't think cares about CARF. I don't think those people care about CARF at all. So, I mean, it is not my personal belief that makes sense, right? That it would lead us to some sort of eligibility that we wouldn't otherwise be able to go after. As far as a financial benefit, that also, you know, right. And as it like transcends down to our funded agencies, I mean, I think the conversation is, yeah, if we have to be upheld to these CARF standards, that means that maybe that is filtering down into the expectations that we have with the funded agencies. But what benefit does that have for a funded agency if they're going after funding or something else? The CARF accreditation doesn't like go with them, or a statement that says, well, you know, we get these dollars from this mental health board that's CARF accredited, you know, like, I don't think that any of that translates. So for me, like, the financial benefit, like I can't see it, you know, but I think it's a great question. And as far as the comments about, you know, making a private, you know, space or third-party space for people to give feedback, I mean, I don't hate that idea. I just question, like, and if and when would that even be applicable, and why would they choose to go to CARF versus, let's say, anywhere else, right? You know, if they've got a concern, because what can CARF actually do about it except give us the message, right? You know, so you know, it's like, while I like the idea, I also think that we try to do I mean, I hope that we do a good job with our staff being very approachable, and I know that, you know, we're scary board members, you know, whatever, no matter who's on a board, people find that intimidating, but it's like, we would hope people would come to us. We would hope that people, you know, would go to our governor, you know, go up to county board, you know, somewhere they would go. So for me, it doesn't feel worth it. And I mean, it's $10,000, but it's also all those hours. So, you know, I feel like we're really doing a deep dive into a small piece of the pie here, but I think we should be doing that level of, you know, scanning through. So, you know, if and when this comes to a vote, I'm going to vote that we let it go, because I can't see that the value is there. And I like that if in some future it becomes hyper relevant again, or we just want to, you know, double check that we're upholding our standards and that our, you know, processes are still to that level, that there's really no, I think that's what we learned in our last meeting, there's really no financial burden of like, ooh, you're going to restart, now it's triple the fee. So, you know, those reasons went out the door for me. So that's where I stand on it. But I really appreciate the conversation about, you know, all the, like, let's look in all the corners and make sure we're not missing something. So, yeah.
My thought is, right from what I've heard and from what everyone has talked about, is that I would vote against it also. But I would like to, whenever you go through an accreditation process, you're always like, oh, wow, that one's going to be hard. We're going to have to put some time into that. So it might be worth, as an internal thing, for us to do an audit of some of our processes, just to see not necessarily because it's a CARF thing, but is there something that we should be looking at as part of our process that we want to, look at a little bit harder? And to me, things like the wait time and taking on extra projects with that would be the kind of things that would stand out if you were getting accredited by somebody externally. So, we could look at the standards and say, hey, is there someplace else where we're falling down? But I would also hope that our executive director, when we get one, would be bringing some fresh eyes to that situation as well. But I liked your questions, too.
And as we're talking about this, I appreciate it, and I'm just going to throw something out there, and it might be, it's new, and so don't think anything more than it just popped in my head, but kind of going in this vein of, I've been talking about like collaboration with the county. I mean, we talked about transportation, we talked about other things. An opportunity that might be here too is there's a county auditor, and if we really feel like, it's something we want to check, have an outside check on us, I'm thinking there could be a partnership that would be viable there. Yes, Melanie?
I just wanted. That's okay. We actually worked with Shannon and her team, and they did do an audit of us, and they looked more into our allocations and our policies and procedures. So we have done that in the past with the county, and, we got great results from them, and they
Great.
wanted to take our stuff and pass it on. So that is something we can do. It's something we have done. They're more than willing to do it, so it is something that can happen again.
And I think, from a board member standpoint, honestly, that kind of has what she's looking at and the consistency of other county offices maybe has a little more value from, versus CARF that is outside, and I don't know a measurable there, and, there's not other, it just from a standardization standpoint and consistency within the county, I mean, there might be some value. I mean, it's great that you've gone through it and know what to expect, and, I would expect nothing less from you guys to, have a really good outcome on that, but it is just another check, and if we feel comfortable, I mean, I think that is one thing we could do instead of, having to pay a significant amount of money, but it's an option. Just throw it out there. Thanks.
Great. No, that is really good to know. Okay, thank you for the discussion. I know that was another bullet point on the agenda, but thank you, I appreciate it. New business? I don't believe we have. All right. Are there any member comments? All right, then I think we need a motion to adjourn.
So moved. Second.
All right, all in favor?